Hi, Mike Gibson, Atul Verma, and we're coming to you live from AHA 2025, and we're talking about a very important clinical question. What do you do with anticoagulation after an ablation for atrial fibrillation? So, Atul, talk to us about where we're at, what you did, what you found, and where we're going.
Sure. So, first of all, every patient who's had a successful AF ablation, the first question they ask is, can I stop my blood thinner?
Yeah.
And the guidelines right now would suggest that if they have a CHA2DS2-VASc score of more than one for males or more than two for females, that they need to continue their oral anticoagulation indefinitely. And the reason for that is we know that AF ablation is not perfect. People can have small episodes. So we don't really know what their risk of stroke is, and the guidelines decided to be very conservative on the issue.
So, what did you do? What did you randomize people to help answer this question?
Yeah, exactly. So what we did was we took patients with a CHA2DS2-VASc score of two or more. If they didn't have, if female sex or vascular disease was a risk, we kind of didn't count those. But we basically said that patients entering this trial would be randomized to either ongoing oral anticoagulation with rivaroxaban, or as the alternative, we decided to choose aspirin. Now, some
And
people
what
might,
dose of Reba did you use, Atul?
yeah, we used a lower dose of Riva, so we used 15 milligrams. But that was based on some pretty extensive data that the outcomes are probably equivalent on the stroke side, but better on the bleeding side.
Yeah, in Pioneer, people with AF and a stent put in, I randomized people to 15 Aviva, and it was the winner in that setting. So I think it's a better dose in terms of safety and good efficacy.
I would agree with you. I would agree with you. So, what was also unique about our study is we included cerebral MRIs for everybody. So, everybody got a cerebral MRI at the beginning of the study, and then they had another one after 3 years of follow up. So, our composite endpoint was actually a composite of stroke, systemic embolism, and covert embolic stroke on MRI. And the reason why we did that is we believe that inclusion of covert stroke on MRI would enrich our endpoints and therefore help us to achieve this with a reasonable sample size.
Of course, in some of the earlier studies with factor 11 inhibitors, not much action there on the covert strokes.
Correct. And actually, in our trial, we had hoped to enroll over 1,500 patients, but the DSMB stopped us after 1,284 because our event rate was so low of
Mm.
strokes and covert strokes that they basically felt that continuing the trial any further would be futile.
Yeah, so tell us what the endpoints were and what the rates were and how they came to that decision.
Sure. So if we look at the overall rate of stroke in any of the groups and the primary composite endpoint, what we found was that the primary outcome occurred in only 5 patients in the rivaroxaban arm, so that's 0.8%, versus 9 patients in the aspirin arm, which is 1.4%. That was not statistically significantly different. The p-value was 0.28. And when we looked at each of the components of the composite, there was basically no difference. But the key message here is that the event rate was very, very low. So in the Riva arm, the annualized event rate for stroke, covert stroke, or systemic embolism was 0.3%. And even in the aspirin arm, it was only 0.66%. So very, very low, much lower than would have been predicted by the CHA2DS2-VASc score. And then on top of that, if you look at the bleeding outcomes, our major safety outcome was fatal and major bleeding. There was actually no difference between the groups, 1.3% in the Riva arm, 0.5% in the aspirin arm. Again, looking at each of the different components, no major differences. However, when it came to clinically relevant non-major bleeding or minor bleeding, it was significantly higher for the Riva arm compared to the aspirin arm.
So what do we do all this? I mean, here you had it wasn't significant, the zero point 0.3 versus zero point 0.6 for the kind of ischemic endpoints, but yet, on the other hand, more clinically relevant non-major bleeds with the Riva. So what do you do?
Well, I think the first and most important message is that in a group of people who received an ablation procedure and were felt on clinical grounds to be successful after 1 year, the overall stroke event rate is very, very low and falls below the traditional threshold for requiring oral anticoagulation. And since we could not detect a difference between oral anticoagulation and aspirin, we would say that oral anticoagulation indefinitely is not necessarily required for these patients. Now, there is a caveat here, Mike, because our average CHADS-VAS score, as I mentioned before, was 2.2. We did have CHADS-VAS 3s who were about a third of the study, and we had CHADS-VAS 4 or more in about 11% of the patients. But if we take a look at very, very high-risk patients, I don't think our results are necessarily relevant to the very high-risk patients.
So what CHADS cutoff would you then use a tool to give someone long-term anticoagulation? I mean, using your kind of expert opinion.
Yeah, so this is expert opinion, but I think that if we had a CHADS-VAS score of greater than 4, our trial would not be in the greatest position to comment on those patients. So being strictly evidence-based, I would say that I would continue to follow the guidelines in those patients. But if the CHADS-VAS score is less than 4, I think that our results would suggest that patients do not need to continue lifelong oral anticoagulation.
Well, Toll, thank you so much. Even if that result was significantly different between aspirin and Riva, that very minor, maybe 0.6% difference in absolute event rates would not be enough really for clinical practice to be all that meaningful. So sometimes we learn a lot from the trials that get stopped early, and this is one of them. So thanks for sharing with us, Atul, and thanks to all of you for joining us here live from AHA 2025.